Welcome to the MAVEN Project's education session on lab tests and rheumatic disease with a focus on lupus with Dr. Katherine Upchurch. Dr. Upchurch recently retired from the UMass Medical Center, where she was a clinical chief of rheumatology for over 10 years. She completed her rheumatology fellowship at Massachusetts General Hospital and Harvard Medical School. She's a professor of medicine at University of Massachusetts Medical School and has taught at all levels to medical students, postgraduate trainees, and fellows. She's been a leader in the Massachusetts Medical Society and the American College of Rheumatology, and was selected in 2017 to be an ACR Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award, given to one area rheumatologist annually for excellence in arthritis care. Dr. Upchurch, you may begin your presentation whenever you're ready.
Okay. Well, first of all, as mentioned, I jumped at the chance to reaffiliate with Sanford. Excuse me. And I must say, I've never taught a group of graduate nurse practitioners before, so I'll have to add that to my level of trainees that I've taught. Today, we're going to be focusing on laboratory testing in rheumatic disease. Let's see. I have to get this to. Okay, Sharice, you have to tell me. Here we go. I have no disclosures. The objectives here are going to be to review briefly concepts of specificity and sensitivity of lab tests, because I think that's really fundamental in terms of interpreting them. And then also learn the appropriate way to use serologic testing in the diagnosis of rheumatic disorders. We'll learn which tests can be used to assist in the management of patients with select rheumatic diseases. And since I'm running the show, I selected RA and lupus. Anyway, and we'll also review when, and particularly when not to order antibody tests. I'm going to get some water because otherwise I will not talk. Hold that thought.
No worries. Just a brief intermission.
You might think that I live in a kennel, but I don't. Okay, so the way I thought I would pursue this and hopefully make it more interesting for you than just a dry presentation was to present two cases who are hypothetical, but every bit could have been cases that you will see or that I've seen many of in my long career. Case one, a 23-year-old woman with an 8-month history of diffuse joint pain, fatigue, morning stiffness for 30 minutes, malaise. Her review of systems was extensively otherwise negative. On exam, she had some tenderness across the MP joints, perhaps a hint of bogginess. She had no rash. And based on this history, and this is what one does as a physician or a nurse practitioner every time you're evaluating patients, you begin to think about pre-testing probability of certain diseases based on the story that you've asked the patient and the patient has told you. So you put together the picture and you say, what is the probability of different kinds of conditions that this patient might have? And I'll have some interaction with you about this as this talk goes on. So case two, also a 23-year-old woman with a 2-year history of diffuse myalgias, fatigue, poor sleep pattern, low back pain. Review of systems was positive for a scaly facial rash with no photosensitivity, which was diffuse. And she did have a history of taking birth control pills. Her exam was positive for diffuse muscle and joint tenderness, no synovitis, and no rash. Again, just put this story together. and ask yourself, what kinds of things would you be thinking of in case 2? And those thoughts often direct the types of labs that you choose to order. Here is a summary of major autoimmune rheumatic diseases and autoantibodies. The antibody type is depicted here in the first column, and then the extensive but very frankly minimal group of rheumatic diseases thereafter. The laboratory studies that one might consider ordering are in the third column, and then there's a synopsis of clinical features. I mean, one could argue that this could be a crash course in rheumatology, and I have no intention of reviewing this entire chart because for the sake of your learning the subject that I'm presenting, I thought it was far more effective if I basically just focused on anti-nuclear antibodies as they pertained to lupus, and also rheumatoid factor and anti-CCP as it pertains to RA. And I think you'll learn a lot about both of these tests, as well as the diseases with which they are most commonly associated. But you'll also learn, I think, some things about the principles of serologic testing, which you might not have considered before now, or maybe you have, and we'll just refresh your memory in that case. So I just want to briefly, before I dive in, introduce you to the concepts of the theoretical aspects of sensitivity and specificity of certain tests. Now, sensitivity is the frequency of positive tests in patients who have the disease. And that's called a true positive test. And that sensitivity is expressed as a ratio of total positive over the total number of patients with the disease. And that includes patients who are false negative as well. The specificity is the frequency of negative tests in patients without the disease being diagnosed. So it's true negative over total without the disease, and that would be total negatives, true negatives and false positives. So if you look down here at the little box, to help you remember, there are 2 words you need to learn: spin and snout. So spin is specific test when the positive test helps rule in a disease. Snout is a word that helps you remember that a sensitive test is when the negative test helps rule out the disease. And I'll be referring to these words quite a bit through the talk. So it's a good thing to just stop for a minute and see if you can get your arms around this particular concept, because it's very helpful in terms of understanding what the value of a test is. Let me see if I can give you a real world example very quickly. Let's think about a serologic test for syphilis. Is that going to end up being a specific test or a sensitive test? Well, it's most likely going to be a sensitive test because most people with syphilis will have a positive serologic test for syphilis. But it's not as specific as it is sensitive because there are other things that can cause that positivity, including rheumatic disease. That's just a concrete example of considering just one test that might help you understand the concept. As we go along, if you have questions, by the way, and I forgot to tell you, one of the advantages of having a real small group is to interact. So, Sharice, if somebody raises their hand, I can't see the people that I'm speaking to, which is one downside of Zoom, I must say.
Yes, if anybody has, please feel free to unmute yourselves if you would like to respond.
And then Sharice can tell me, or you can point to you, and I'll stop, and we can talk about whatever the specific question. So the other thing, and this is not specific to any one lab, but it really refers to your overview and how you approach the patient who walks in the door. So when you see a patient, if you're a rheumatologist or you're in rheumatology clinic that day, or if you just happen to see a patient with this kind of complaint, inherently the patient's going to have musculoskeletal pain because that's their presenting complaint. So if you see a patient with musculoskeletal pain, you really have to step back, look at the big picture, and first figure out, is the pain that's being described in the joints? Because there are other things that can hurt, such as the area around the joint called the bursa, or generalized pain, which often happens in fibromyalgia, or pain in muscular pain, which is often seen in low back pain. You can get that answer by taking a detailed history and doing a physical exam. Sometimes you can do, if you're with someone and they know how to do it, or if you end up being a rheumatologic nurse practitioner, you can learn to do musculoskeletal ultrasound. Sometimes that helps. So you can see that there's an issue with a joint, or you can tell if there's inflammation in a joint with a musculoskeletal ultrasound. So occasionally that's useful too. But there's nothing really in here that indicates that we would draw any labs that would answer the question, is the pain in the joints or not? That is derived by a detailed history and a physical exam. So that's where it all starts. One of the reasons I love rheumatology. The next question we want to know is, if we decide that this is, particularly if we decide that it's in the joints, we would like to know if the pain that's being described is inflammatory or not. Now we can get the answer again by history, physical exam, and in this case labs, and newer trained rheumatologists do use ultrasound on occasion, particularly color Doppler ultrasound, which basically exposes inflammation beautifully. So we would ask historical questions such as, is there any redness in the joint? Is the pain worse in the morning? Is it worse when you stay up on it, or does it get better? We might want to know if there's been any observed swelling. There's a whole host of questions that we'll review in a minute. But we would order lab tests in this circumstance that can help us look for inflammation. And the lab tests that we'll order would be a sedrate and possibly a C-reactive protein and a CBC. Now, I'm not going to spend any time going over the biology of the sedrate and the CRP, but suffice it to say that the sedrate will often be abnormal in patients with inflammatory conditions and can be a clue that your supposition of inflammation is true, as can the CRP. Neither of these is 100% specific or sensitive for inflammation. So you're not going to hang your hat on it. And a negative sedrate or normal sedrate and even a normal CRP can be seen in patients who have extensive inflammatory scenarios, but that's not the norm. And then if we do get a sense with the sedrate and or CRP, our history, physical exam, lab, ultrasound, et cetera, if we do get a sense that in fact it is an inflammatory condition, then we have to say, well, gee, what could it be? Again, the answer starts with the history, the physical exam, and also we do depend and order specific labs. I'm using the word specific loosely here, certain labs. And those labs in the setting of inflammatory arthritis would include a rheumatoid factor, an anti-CCP, and an anti-nuclear antibody most of the time. And frequently we would get a urinalysis as well. The urinalysis to make sure that we don't miss diseases that include renal dysfunction, but also inflammatory arthritis. So I can't emphasize enough, and I'm glad that I'm spending a little time on this slide, because history, physical exam, and using your brain and what you know about musculoskeletal disease, and in particular rheumatologic disease, is absolutely the starting point and the ending point of making the diagnosis in this situation. Now, what types of presentations might there be, and what types of tests might one do? So acute monoarthritis means one joint's involved. Chronic, of course, is for a longer period of time, but acute is within a matter of days, hours, days, or even a few weeks. Chronic might be months to years, and there might be one joint or many joints. Arthralgias and myalgias are other ways of expressing pain that's not accompanied by objective findings on exam. And then there are vasculitic syndromes and other syndromes, thrombosis syndromes, recurrent miscarriages. And these are some priority tests that you might do, and some secondary tests that you might do in the setting of any of these situations. These slides, I think, are just for you to have and hold and come back and refer to later on, because what we're going to start with now is the real essence of the talk. So if you have a patient whom you think has inflammatory polyarthritis, I call it IA as a contracture, we've ordered a sed rate endo CRP, and if those are abnormal, we've ordered a rheumatoid factor, an antibody to citrullinated peptide antigen. Now, if every single one of those tests is normal, all of them are normal, rheumatoid arthritis or inflammatory arthritis is less likely, although on rare occasions, early in the disease, and this is a pearl, rheumatoid arthritis and other forms of inflammatory arthritis may, but uncommonly, have normal sed rate and CRP. And how closely you follow a patient going forward depends on which of these tests are abnormal, if any, but it also depends upon your suspicion based on your history, physical, and labs of the disease. So I've told you that sometimes patients with rheumatoid arthritis don't have any findings. They don't have any clinical findings. They don't have any abnormal laboratory. So those are the patients that, quite frankly, most commonly are blown off. And they're blown off often because they're young women. They basically fall into the demographic catalog. I'm not even going to stumble over that word anymore. They fall into the demographic catalog of being a young woman much more commonly than men, or in particular older men. Although all of those subsets can develop rheumatoid arthritis. But it's the young woman who looks healthy, who maybe is not as articulate about describing his or her complaints. And it's also maybe the observer or the listener who's not really asking the questions that generate the picture of someone with inflammatory arthritis that lead to the maelstrom of the person just not being paid attention to and being assumed not to have disease. I would hope that you would not fall onto that wagon. And if you are worried that you might have missed a diagnosis, the easiest thing to do is just have the patient come back and see you and find out how things go. Now, depending upon your sense of the likelihood of disease, you can consider other tests as mentioned here. And we'll be talking further about some of these other tests going forward and why in particular they're helpful. But let's turn to rheumatoid factor, which is the first actually abnormal antibody that was discovered in rheumatic disease way back in the 1940s. And it is known now to be an autoantibody, so it derives from the affected individual's person, and it's directed against the Fc fragment of IgG. And as you know, there are different types of autoantibodies of immunoglobulins: IgG, IgA, IgD, IgE, IgM. But rheumatoid factor is an IgG always, and it specifically adheres to the Fc fragment of IgG. Now, when you ask the lab to measure rheumatoid factor, most commonly they are measuring IgM rheumatoid factors. So IgM is the experimental substrate. They put the patient's serum in a test tube with the experimental substrate, and they see, one of the most common ways is see if it agglutinates. And sometimes early on, they would coat a latex bead with IgM, put the substrate, put the coated beads in a tube, add the patient's serum, shake it up, and it would flocculate or turn cloudy when all of the rheumatoid factor caused conglomeration of the latex covered beads. Sometimes you see IgG rheumatoid factor, hardly ever IgA rheumatoid factor, but they're all directed against the Fc fragment of IgG. Now, not every patient with rheumatoid arthritis, clinically defined, has a positive rheumatoid factor. There's a wide variety, and we'll see some more numbers down the road, of studies that have looked at this over the years, and the incidence varies from 60 to 80% of patients. And if you flip that around, that means that up to 40% of patients in some studies are said to be rheumatoid factor negative, and yet they have all the features that you would expect of rheumatoid arthritis. And that predominantly would be polyarticular, symmetric, progressive inflammation of typical joints. Now, it turns out that about up to 5% of normal individuals have a positive rheumatoid factor too. There are a couple of ways you can distinguish between what's unusually positive and what's not. Patients who have a rheumatoid factor for no apparent reason, without apparent rheumatoid disease, typically have very low titers, but they're reproducible. So you can see positive rheumatoid factor over and over and over again, but it never gets out of the realm of very low titer. And the upper limits of normal of different labs varies. So it pays to know what the upper limits of normal are of the lab that you use. Now, prognostically, high levels of rheumatoid factor are associated in rheumatoid arthritis with more severe joint disease and also with extra-articular disease, including rheumatoid nodules, vasculitis, lung disease, even severe eye disease with scleritis and perforation. Now, one other issue about rheumatoid factor that you should be aware of is that it is positive in other rheumatic diseases and in chronic infections, again, in lower titer than one would expect in a patient with true rheumatoid arthritis. Now, the last thing I want to tell you, and hopefully you figured this out, is if it is present in other diseases and it's present in normal individuals, it's not the test that is pathognomonic for rheumatoid arthritis. There is no test that you would order and say, oh, the rheumatoid factor is positive, you've got rheumatoid arthritis. Can't be said, can't be done. Rheumatoid arthritis is a clinical definition of disease, and it's only when the clinical features of the disease are apparent can one make that diagnosis. Now, I thought you'd be interested to see the structure. So this blue molecule is a large IgM molecule. Now, and it has these it has 5 binding sites because it has 1 Fc fragment in the constant region, which is this region here. So there's 1 Fc fragment in each of these to which rheumatoid factor can bind. It's never really been understood why, even though there are potentially 10 binding sites, only 5 IgGs, which are the rheumatoid factors, will bind, but that's what happens practically. Now, an IgG rheumatoid factor would have 1 rheumatoid factor binding to 1 Fc fragment, and that's it, because that's what the IgG structure is. But the IgM structure is this huge molecule. It's possible that this has some pathophysiologically derived importance. We don't know if rheumatoid factor actually participates in any of the destructive activities of the disease. It could just be a marker that is caused by chronic stimulation of the immune system. But we do know that it is often seen in rheumatoid arthritis. So let's talk a little bit more about it. I've already said it's an antibody directed against the Fc fragment of IgG. And IgG itself is the predominant immunoglobulin in normal serum. I've said that IgM rheumatoid factor is most commonly measured. I've said that it's present in 60 to 80% of RA. I've said from a prognostic point of view that it has high levels, and I've said that it's associated with other diseases, that high levels are associated with extra articular complications of RA. And I've also said that it's present in other rheumatic diseases. It has some other utility, however. So I've already told you that it assists in the diagnosis. So the presence of rheumatoid factor in patients with compatible findings, symmetric chronic polyarthritis, it increases the certainty of a clinical diagnosis of RA if other causes of rheumatoid factor are excluded. It also, and we just talked about that, assists in prognosis. And in most labs, more than 50 international units will put you into that high titer group. And because of the fact that patients in high titer, with high titer positive rheumatoid factor do have more likelihood of extra articular complications and progressive disease, it persuades caregivers to institute disease modifying drugs early on and to be more aggressive with treatment. So it's all around a helpful thing. Now, it's not a screening test, and this is the specific information that I promised you. So the prevalence of RA, that is the number of patients at any one time, is about, most people quote about 1%, maybe just a little bit lower. And we know that the upper limit of positive rheumatoid factor is about 80%, the figure that I quoted, 60 to 80%. But let's consider chronic hepatitis C. Well, the prevalence of chronic hepatitis C is twice as high as the prevalence of rheumatoid arthritis. And the rheumatoid factor positivity rate in hepatitis C is just a little bit lower than in rheumatoid arthritis. So what that means is, if you see a patient who has a positive rheumatoid factor, he or she is equally likely to have hepatitis C as the etiology. And the implication is, if you see a patient, even with polyarthritis, and who has a positive rheumatoid factor, it behooves you to get a hepatitis C. And of course, now it's a public health recommendation to test individuals who were demographically in the right age group to have transmission of hepatitis C some years ago. So I think the age cutoff may be 40, could be 50, to test everybody who's 40 or 50 or older for hepatitis C, but especially focus on patients with a positive rheumatoid factor. That's a great attending PEMP question, is to catch somebody who didn't test for hepatitis C in a patient with arthritis, and particularly low titer positive rheumatoid factor, because it is true that the hepatitis C joins the vast group of infections that can have positive rheumatoid factor, and the titer in which they present is much lower than true rheumatoid arthritis. Okay, so what about the other diseases that can have rheumatoid factor positivity? I said rheumatoid arthritis, but we also see it in a variety of other rheumatic diseases, such as Sjogren's syndrome, lupus. Now, Sjogren's syndrome deserves a little moment because it's a disease of pan-positivity of autoantibodies. So just about every disease, every antibody known to man will be positive in patients with Sjogren's syndrome, including rheumatoid factor. In lupus, 15 to 20% of patients may have a positive rheumatoid factor. And in mixed cryoglobulinemia, up to 95% have positive. That's a complex disease, and I'd love to give you a talk at another time about mixed cryoglobulinemia, but suffice it to say, particularly if you see a patient with low titer positivity and certain clinical manifestations, especially Hep C, mixed cryoglobulinemia could be the culprit. Mixed cryoglobulinemia, parenthetically, is a form of vasculitis. Patients with sarcoid can have this, and patients with chronic parvovirus, not chronic, acute or subacute parvovirus infection can be positive as well. Other chronic infections, chronic Hep C, I said, chronic osteomyelitis. Interestingly, SBE is known to be associated with positive rheumatoid factor. I just left the kennel. My dog is misbehaving this morning, and I thought I had it under control, and I do apologize, but hopefully it won't be a problem going forward. In any event, there are circumstances where hematologic conditions in which there's an excess of clonal antibodies can have rheumatoid factor activity. So we do see in lymphoma positive rheumatoid factors, and the same is true. Waldenstrom's macroglobulinemia is actually a monoclonal IgM paraprotein. And I also mentioned that with normal aging, rheumatoid factor is present at low titers. So what this tells you is rheumatoid factor is not a specific diagnostic antibody, but in the right clinical suspicion, with the right clinical suspicion, the diagnosis is pretty easy to make of rheumatoid arthritis. I want to turn now to citrullinated peptide antigen. and cyclic citrulline peptide antigen, ACPA and anti-CCP. So citrulline is a modified amino acid which is derived by a chemical change, a post-translational chemical change in the amino acid arginine. So you would not find citrulline in an unborn baby, a fetus, but at some time after birth, there can be a post-translational modification in which citrulline is substituted for arginine, and it generates a series of autoantibodies. Now, in some patients, certainly not all. Autoantibodies to citrullinated proteins contain citrulline within the peptide, and when that's present, it's highly specific for RA. So there are many fewer conditions that have positive tests for citrullinated peptides who don't have RA. So it's uncommon to see this antibody in other conditions. Now, sometimes the test called ACPA, instead of just employing citrulline peptides as the substrate for testing, they use cyclic citrulline peptides. So they're literally circular. And those tests detect antibodies to cyclic citrulinated peptide, and that's called an anti-CCP. So an ACPA is not cyclic, and an anti-CCP is. I simply tell you that because you will hear both names, but the presence of ACPA versus anti-CCP doesn't have any clinical significance. It may just be that the labs use one versus the other, and you might be interested to find out which. Now, ACPA or anti-CCP has a similar role as rheumatoid factor. It's similarly sensitive, but it's more specific. And remember what I said, there are fewer diseases that can falsely be positive without having rheumatoid arthritis. For example, they're less common than in Sjogren's and in lupus, although occasionally you do see these in Sjogren's and lupus. They are not seen in chronic hepatitis C, and they're not seen in other infections. They do predict severe and erosive disease. They can be present in early synovitis. Now, these antibodies are not perfectly correlated with rheumatoid factors. So some patients are discordant for rheumatoid factor and anti-CCP. Most RA patients are positive for one and the other, but you can have some that are positive for anti-CCP, but not rheumatoid factor, and conversely. Anti-CCP antibody has a strong association with genetic risk for having what's called the shared epitope, which is a particular configuration on the DR4 molecule that confers extreme risk for severe disease. Oddly enough, as you see, all of these percentages are very low. SLE, psoriatic arthritis are the highest, JIA. Active tuberculosis is associated with a very high false positive ACPA test, and this depends upon the test. There's some sort of quirk in the system. It's never been defined that active tuberculosis has anything near like an arthritic syndrome that even remotely resembles a rheumatoid arthritis. And it's speculated to be something to do with the actual test itself. And I intended to look it up so I could share and enlighten you all a little bit more about it and myself, but I simply didn't have time to do it this week. So if any of you are interested in knowing why this figure is so high, I'll dig it up soon and give it to Charisse, and she can pass it on to you. But it's certainly not a marker of the combination of active TB and arthritis. So as you can see, that would place anti-CCP-ACPA in the quite specific end of the specificity sensitivity axis. So there are a few other things that present with high titers of, or even low titers of ACPA tests. So this is a summary. Over the years, there have been many different studies in many different populations of patients, but this is a summary of sensitivity and specificity in early RA and also in early and established RA. The sensitivity in ACPA is anywhere from 41 to 63%, and in rheumatoid factor, 41 to 66%. The specificity is 91 to 100%. Now, the specificity of early rheumatoid factor in early RA, those figures seem high to me, but from these studies, that was what was identified. Now, as you can see, they go lower in the early and established RA. The sensitivity of ACPA is no different. The specificity is quite high. And in rheumatoid arthritis, the specificity is broad. It can be as low as 43% in some studies and as high as 96% in others, likely someplace in the middle. But the conclusion is that ACPA is about equally sensitive as RF in early RA, but it's more specific than RF for a diagnosis of RA. And one would expect to see it in a moderate to high titer, but frankly, when you see it at all, it's certainly worth paying attention to, because there's so few things that can cause it to be present even in low titers. So I'm going to stop here for a minute and see if anybody has any questions about any of this, because we're going to turn to anti-nuclear antigens now, and maybe there are some thoughts or questions that you might want to share at this point.
Yes, if anybody has any questions, feel free to unmute yourself. We don't have any questions in the chat as of right now.
Okay, well, that must mean that it's early in the morning and maybe you haven't had your coffee, or it possibly might mean that what I've been saying seems to make some sense to you. And hopefully you've learned something so far. So we're going to move into.
I have a question. You were talking about the chronic hepatitis C and the RA. They can both have a positive rheumatoid factor. Is there, with arthralgia, is there anything else that should be in the differential if you have a patient that has a positive rheumatoid factor and arthralgia besides those two things?
Oh, absolutely.
So it should be basically that whole list that you just gave us.
Well, I know what you're asking. So you're saying you need to check for hepatitis C if you see a patient with arthralgias or polyarthritis. And if the hepatitis C is positive, it's a difficult thing to know whether actually I've had a patient exactly like this, and whether it's the patient has arthritis from rheumatoid arthritis and has hepatitis C, or whether they just have hepatitis C.
Yes, yes. Okay.
Oh, that's your question, right?
Yeah.
Well, ACPA is one way to separate these two. So the patient that I saw had a very high titer positive rheumatoid factor. He had polyarticular symmetric arthritis, and he had a very high titer positive anti-CCP. And that means that he had both. And he had a liver biopsy that confirmed that he had Hep C, and he had serologic studies which were completely compatible with that diagnosis. On the other hand, if you can't prove you have to, in order to have chronic Hep C, you have to have serologic abnormality, right? And you wouldn't want to open up every case that you see who has polyarthritis to the entire differential diagnosis of polyarthritis, which is about 100 different diseases, when you've got an explanation with the two diseases or one disease that you're dealing with. Does that help at all? I mean, you asked what the differential diagnosis is. Well, the differential diagnosis of a patient who walks in the door with polyarthritis is extensive. And by narrowing it down with testing, you're going to get into the right realm of what likely is going on. So with anti-CCP that's negative, it's most likely going to end up being Hep C related if you haven't found anything else. And you know, you're going to do a series of other just quick, broad brushstroke things. But for the most part, you're going to check if the patient has psoriasis all over the place. Maybe you'll say he's got psoriatic arthritis instead of rheumatoid. But for the most part, you're going to end up with the diagnosis of rheumatoid arthritis. Does that, if he has a positive ACPA, and Hep C if he doesn't?
That helps a lot. Thanks.
Does that help?
Yes, thank you.
Okay. Let's see. And it's a hard thing to separate. Now, I'm just very quickly going to go over this because I'm proud of this name right here. That's me. And I participated in a small group of people from the American College of Rheumatology in going through a 2-day exercise to try to revamp the classification of rheumatoid arthritis. I put this in because I want you to be aware that these classifications are not to tell you, not to provide a crutch for diagnosis. They are to make sure that everybody that's included in studies has the correct diagnosis. So we wouldn't want to put someone in the study who does not have arthritis, for example, and have him just put in a study and skew the results. But the point that I'm trying to make here is that in this classification, this is the first time that ACPA was included, and this was in 2010. So the 1987 classification criteria did not include ACPA, and it's made a major difference in terms of understanding the disease as well as especially diagnosing it. The other point to make here is that the duration of disease is you don't get any points for less than 6 weeks duration, and that's because there's so many other things, particularly viral infections, that can cause joint pain over a 6-week period. But if you have sustained pain for more than 6 weeks, it's more likely to be a much smaller group of chronic arthritic syndromes, of which rheumatoid arthritis is the most common. Okay, now I'm going to turn to the cases again that we talked about. So case 1, I'm not going to read it again, but case 1 had synovitis, and case 2 had diffuse myalgias, didn't have any physical findings, although she did have a facial rash on review of systems. So I ordered a SED rate and a CRP in both patients. In case 1, the SED rate was 50, CRP was 20. And 20 is a very high number for the, not the high sensitivity, but the conventional CRP testing. And in case 2, the SED rate was 10 and the CRP was 1. So neither of these laboratory abnormalities in case 2 were abnormal. Case 1, it provided some corroboration of the clinical impression of, yes, there was a high pretest probability. And in this situation, when I considered it, I said, no, I don't think that there's going to be a high pretest probability. And sure enough, the lab did confirm that. And I'll come back to some more labs on these patients in just a little bit. Okay, so here you have this patient, and I've gone over this slide before, but I'm going to stop here. This is where we are now. So we found an elevated SED rate, and we added rheumatoid factor and ACPA, and we've considered an ANA, so we're going to go ahead and get an ANA. Now, in the real world, we don't necessarily bring the patient back after each lab test and say, well, that was normal, so we have to get another lab test, or that was abnormal, so we have to get another lab test. We basically often do, especially rheumatologists, a broad brushstroke of lab tests, some of which we're pretty sure are going to be negative and some of which we're pretty sure are going to be positive. But I'm trying to discipline you to think about the patient and to analyze your thoughts and organize your thoughts about what the likely diagnosis is as you go. But here, the inflammatory markers were abnormal. So we're going to turn to the anti-nuclear antibody testing. Now, you all know about test techniques. I don't know how much you learned in school, but the classic test technique is an immunofluorescent assay, and it uses a immortal cell line of human epithelial cells, and they are plated on slides, and then they're covered with the patient's serum. And it turns out that the cells are immunofluoresced and the nuclei immunofluoresce if the antibody adheres to the slide. So if the patient has a positive ANA in their serum, you're going to lay their serum on top of the antibody, on top of the slide. You're going to wash the slide off. The patient's serum is going to stick to the slide, and it's going to be and there's going to be immunofluorescence to develop the slide, and it's going to be reported as a pattern and a titer. Now, the ANA is 95% sensitive with regard to lupus. So it's a very sensitive test, but it's not very specific at all. So 20% of normal patients have a positive ANA at 1 to 40, 5% 1 to 160. And also, sometimes the anti-SSA or anti-Rho antibody, which is one of the many antibodies that have clinical significance and that I'll have to talk to you about at another time, is missed altogether. So nonetheless, the concept of ANA negative lupus, which in the old days was felt to be reasonably likely, is almost never considered to be so in these days. Now, there's one thing I want to make you aware of. You need to know your lab with regard to ANA testing. Why do I say that? Well, the traditional immunofluorescence test is very labor intensive, and a tech has to look at the slides and look at the nuclei, categorize the pattern, and report out. Not only that, they have to dilute the serum until the slide is negative. Now, that is really a very, very long process and expensive process. So there have been a lot of ways to try to get around this. One is that the multiplex technique has been developed. And in this technique, little beads are coated with known antigens, different antigens that might be present. And the antigen mix is different. It's not the same for every lab. But for the most part, there are antigens that are often seen in patients with lupus. However, there is no global reporting of positivity. So if any one of those little beads is positive for an antigen antibody complex, then that will be reported as positive. But there may be antibodies that simply aren't in the mix of those beads, and the patient will be reported as ANA negative, even though they do have what would have been ANA positive by the immunofluorescence technique. Sometimes labs will listen to a rheumatologist and will go back and do an immunofluorescence. And it is true that the ANA by multiplex, or Quest calls it ANA choice, they have some very specific tests, which we'll learn about in just a minute, that if negative, reduce the likelihood of lupus, but they don't make lupus likelihood negative. So immunofluorescence is still, I think, still has a place. It's 95% sensitive with regard to lupus. And I think that has to be remembered. The ANA by MIA is really going for the specificity, not the sensitivity.
Dr. Upchurch, I just wanted to, I'm sorry, we are wrapping up. We're kind of at the top of the hour now.
What? I just looked and it was, what time is it?
Yeah, it's 11:01. So if you don't mind just wrapping up, my apologies. I'll be sharing today's slides with everyone today.
Yeah, let me
So we can
let me
get
just
into our
quickly run.
second half.
That's fine. I will quickly run through because this is this is an important slide because it shows all of the associated non-rheumatic diseases. Okay, so that speaks for itself, and I definitely would look at this slide. But most of them are autoimmune diseases, and then there are many rheumatic diseases that do. There's a very good flow sheet that I think you would probably want to print up and refer to, how you look at a positive ANA. And this again depends upon whether you have a high likelihood, you think there's a high likelihood. There are reasons for repeatedly false positive autoantibody tests, and we all see patients who have low titer positive ANAs, and they have them for their lives. Very frustrating for them and for the doctor. This describes the specific and the sensitive antibodies for lupus and specific. So anti-DNA is 95% specific. Anti-SM is very high, 95% specific. So most patients won't have those, but when you have anti-DNA and when you have anti-SM, you've got lupus, okay? Now, the other thing I wanted to point out is that there's a new EULAR classification criteria for lupus, and this is something that you would want to review. Fever has been added if it's chronic compared to the old, but the other thing is that you can't even get into this dialogue unless you have a positive ANA. Again, this classification is not to help you diagnose lupus, it's to treat patients with lupus, but inevitably you will be asked how many criteria did your patient fulfill, and you have to have a total of 10 and they're assigned points, and you can see that. Turned out patient, patient on the left was the one that did have lupus. She had a positive anti-Smith and she had negative anti-CCP and RF. The patient on the right did not. One more slide, okay?
Okay.
One more. So that patient on the left was the one that you would tell, don't go out in the sun. You can use these to monitor activity of lupus and target organs, but please, I'm going to send you off with this thought. Please don't order repeated rheumatoid factors or anti-CCPs once the diagnosis of RF is secure. Every single rheumatologist, and the same could be said of ANAs, rheumatoid factor and ANA are not used for monitoring purposes ever. And it's every single rheumatologist will have a patient who calls and says, well, my primary physician ordered a rheumatoid factor and it had gone from 1 to 80 and now it's 1 to 360. And so they sent me back to you. That has no bearing on clinical progression or lack thereof of either lupus or rheumatoid arthritis. And if you'll look through the last couple of slides, you can see how some of these tests can be used to monitor disease. And it's very important to follow patients with certain laboratory tests, but not ANA and not rheumatoid factor. And with that, I will I will close the talk. And there's some
Thank you so much, Dr. Upchurch. If you have some time, I know we're getting into our next presentation. We want to give everyone a couple of minutes to themselves before we get into the second half. But Dr. Upchurch, if you are available to stick around for that second half, and maybe if people have some questions from your presentation, we can do kind of a combined Q&A.
Do you know, I don't have today. This was kind of wedged into a otherwise very busy day. And
well,
I want to also apologize a lot for the dog. That's my daughter's dog, and he was just off the charts. And it's the first time in weeks that he's been like that. So I'm very sorry.
No worries, Dr. Upchurch. Thank you so much for your time and expertise and sharing your knowledge with us all today. For everyone here who wasn't able to get their questions answered, please feel free to use our VC platform. Dr. Upchurch is available to receive consults using our on our VC platform. So please feel free to reach out to her.
Or you know what, Sharice, I haven't put specific times out, so just have them funnel the questions to you, and then you can send them on to me. Okay.
Oh, okay. So all right. Sounds good. Thank you so much, Dr. Upchurch. So we're gonna just take 4 minutes just to do a quick break, and then we will start with Dr. Kleinsinger's presentation on medication non-adherence part 2. Thank you again, Dr. Upchurch, for your time.
Sure.
All right, so we will get back here. Let's start at 11:10.
And somebody had something to.
I'm sorry. I'm Tanya Shanahan. I'm one of the faculty members at Sanford with the NPR program. I just need to make sure Sarah Roman, our publicity media person from Sanford, was going to come on and just do a little screenshot for the NPR newsletter. So I want to make sure that everybody's camera's on and there's lighting in your room so your face can be seen. Ashley, if you can just get some more light, and Demetra, if you can just get some more light so when they take this picture, they'll actually be able to see faces. Like I said, Sarah's going to do some screenshots, and I think those will be in the NPR newsletter. So I'd appreciate that.
So they're not going to be, they won't see me, right? No. Okay.
Okay.
I mean, unless you want to join, Dr. Upchurch. If you would like to join, I think that would be nice. No, okay.
No, I mean, I'm not really dressed for the occasion.
And then Dr. Kleinsinger just hid himself very quickly. Thank you, Dr. Kleinsinger, for your patience today.
Yeah, I'm sorry if I didn't even know there was another talk.
No worries, no worries. So yeah, we could take a picture if you'd like. Dr. Upchurch, you can, feel free to stay on and, take a picture for the Sanford newsletter. If not, you feel free to end the call.
I'm not really sure when I saw her jump on, and I saw her
jump in. Yeah, I seen her jump in. I think she jumped back.
She'll probably jump back in a minute. I think she heard we were about to take a break.
Okay.
So I just wanted to put that out there. We might not know when it's happening. Ashley, I'm sorry, I still can't see you. Your room's dark. If you could just get some light, just so your pretty face will show up for our newsletter. And like I said, I don't know, I actually saw Sarah jump on. You'll probably see her pop back up. So she'll be the one doing it. I'm not the tech person, but let me hush so you can have your break. Thank you all.
Yeah, so we're going to probably get started just in the sake of time in about a minute with Dr. Kleinsinger's presentation. So if Sarah doesn't jump on before then, we'll probably get started with Dr. Kleinsinger's presentation, if that's okay. Dr. Kleinsinger is here with us.
Sure.
And
why doesn't everybody stand up for a minute and shake a little bit? It's very hard to go from one presentation to the other.
That is very true.
So, and if you need to go to the bathroom,
I have my PJ bottoms on, so y'all be.
I actually got dressed for this, so.
Yes, this is good. Get the blood going. Yeah, I'm business casual from the top up, from the bottom down. I'm very comfortable, and that's my new style for the quarantine. So thank you, Dr. Kleinsinger, for that. So I just want to give a little introduction. Dr. Kleinsinger, as you guys met last month, he will be doing the part 2 of medication non-adherence. Just to give you guys a little bit of background, Dr. Kleinsinger is an assistant clinical professor in family and community medicine at UCSF School of Medicine. He retired after practicing medicine for 38 years. Although he initially practiced at community medicine clinics and in private practice for 5 years, for the last 13 years of his practice, he was a physician in the medicine department at Kaiser Oakland Medical Center in Oakland, California, where he was an assistant chief of medicine. And he developed and administered the mentoring program for the new medicine department physicians. He also was involved in introducing the electronic health record to the medicine department physicians. Since retirement, he's been active in teaching first through 3rd year medical students at UCSF. He also has developed and led CME workshops on a variety of topics at regional hospitals throughout the state of California. He has published 3 articles on the topic of medication non-adherence, which is a special interest of his. So Dr. Kleinsinger, you may begin your presentation whenever you are ready.
Okay, well, I'm ready now. It's good to see you all again. I wanted to at least see my face for a second here, so you know that it's not a robot talking to you. But now I want to share my screen to, if I can do that correctly, so I can. I'm totally dependent upon PowerPoints these days. Okay, screen shared from beginning. From beginning. There we go. Okay, so I recognize some of the faces. So some or many of you were here for the presentation last time on this, in which I talked about the causes of medication non-adherence, and stressing that this was an extremely common problem, and that if you look nationally, as few as 50 to 60% of patients with chronic conditions take their medications appropriately, which means 40 to 50% don't. And as you would expect, since we believe that when we want people to take medications for high blood pressure, COPD, diabetes, that they actually work, the people who don't take the medication do worse. So, and again, summarizing the last time, there are multiple factors that contribute. This is not a simple problem. And basically, the profession of medicine, in my opinion, thinks it's too easy. You just say, you, Mrs. Jones, you have hypertension. That's a bad thing. If you take these pills, you'll get better. Any questions? Great. That's a parody, but that's actually what does happen a lot. And not surprisingly, when people get so little understanding of what's going on or what's in it for them, they often don't follow through. Now, there are a lot of other problems that create non-adherence, but the most important one is that the patient doesn't really understand or appreciate why we're trying to get them to take medications. Because if we're doing our job correctly, the patient will come into your office and say, I want my medication. I need it. Why are you keeping it from me? Well, that doesn't happen that much. So since the last presentation, I know that many of you, oh, by the way, I like these presentations to be as interactive as possible, which is a limitation with Zoom. So please, when I stop to ask for participation, I really do appreciate it. You learn by doing, by participating. You don't learn so much by sort of sitting back and absorbing by osmosis or a sponge the wisdom that's being, led to you. So a first question for the group is, for those of you who took this before, I know it's an urgent care practice, but have any of you noticed any cases, identifying examples in the work you were doing of patients who are being non-adherent to chronic medications?
Feel free to unmute yourselves. Yes, if anybody has anything, feel free to unmute yourselves or share in the chat box.
Okay, I'm going to take that as a no. But please, does anyone have anything they want to say? I mean,
I think Trey and Demetria unmuted themselves.
Okay,
Yeah,
Trey, go ahead.
I had a patient. I had a patient yesterday who is a type 2 diabetic, and she had recently
Roz, not here.
recently diagnosed about 2 months ago. A1C was only 7.4 prior to the initiation of medication. She did not tolerate metformin, was placed on glipizide, came in, like I said, yesterday, which was only 2 months after her last visit. So it was too early to draw another A1C, but she had been reporting high levels with her home glucose monitoring. And that morning we did a finger stick of 392, but the gist is not only has she not been, taking her glipizide because she said she didn't like the way it made her feel, but she had also been using her mother's Novolog without any education on how to do that to try to control her sugar. So I had to spend a considerable amount of time kind of talking with her about the dangers of doing that, and kind of educate on how the glipizide works. Why did we not take it, and what other options we wanted to explore with her.
Great. How do you think that worked?
I think it worked. I think we'll see. I feel like she listened to what I had to say, and what the other provider who followed me kind of echoed some of the same thoughts. We ended up, it wasn't that I think for some reason she thinks a medication via injection is a better choice for her. So we ended up doing Victoza, and so we're going to see how that works.
Okay, I think that's great that you spent the time with her, Trey, and that you also got into some sense of understanding why she wasn't taking the medication. We can't go into this in more detail now, but she believes that shots are more effective than pills. And so you need to work with that, because, you are not going to go home with her and show up at her bathroom every morning and say, here's your glipizide. She has to be motivated to do that. So great. Now, does somebody else have something they wanted to say? I can't see
Yes,
all of you.
we have Demetria who would like to share something.
Shoot.
I was just saying, yes, in urgent care, we're still experiencing that, and that we have patients that come to us for medication refills. I asked them when the last time they've seen their primary care physician. It's been 2019 or the beginning of 2020, and they've been out of medications for 2 months, but they just choose a random day to come in for refills, and they haven't had the proper blood work and things like that.
Yeah. So how did you deal with that, Demetria?
I provided a primary care physician list to them. We did, of course, refill their medications, and pretty much educated them that not only do they need to take medications, but there are certain lab works and certain other things that primary care physicians provide that we don't in urgent care. We kind of treat and treat, whereas you get a thorough workup in primary care.
Okay. That's terrific. You helped explain to her that the role of urgent care versus primary care, and that she needed to be seen and monitored. She can't just come in. Well, she can, but it's not optimal for her to come in and just say, I need a refill of this and that and that, and you don't know what the status of it is, and it's an urgent care clinic. You don't know her. Having said that, as a primary care doctor, and someone who's on the receiving end of the, patients who need to be monitoring, it's really good that you help her out, and to whatever extent you're able to educate her about this and steer her in the right direction. So, and the first step, as you did, is to ask her more questions about what was happening. So that's great. So even in urgent care settings, this is an issue. And now I presume, I'm not sure I'm right, but I think this urgent care setting is part of your internship. Once you finish the actual training, you all may be going into a variety of settings, which include primary care settings. Is that correct? Or are your careers likely to be mostly urgent care?
That's correct.
Which is correct?
The first.
Oh, okay, cool. Well, that makes this more relevant. Okay, so going ahead with the presentation. Let me move all your faces. I can't read my slide. Okay, the goal is to give you an overview of techniques that can be used to improve adherence and to facilitate development of a specific adherence improvement plan for participants to use in their practices. In other words, I said this last time, I'll say it again. My goal in offering, continuing, medical education is not just to tell you interesting things, but to have an impact on changes that you will make in your practice. And my experience in both teaching and also being a recipient of medical education is that if you see things that you want to do to change, if you don't immediately implement them, they're going to get lost because you've got so many different inputs and so many pressures from many different things. So I'm going to encourage you throughout this presentation, which I'm going to touch on multiple ways to help people improve their patients' adherence, that you look for 1 or 2 or 3 and say, hey, that appeals to me. Write it down and try it out today or tomorrow, this week. Well, not much. We have not much time left this week. Next week, because if you don't do it, then it's going to go into the background again. Now, I asked MAVEN to send out a list of different of things you could do to improve adherence with your patients. Did you get that list?
Yes, it was sent over to the team yesterday. So
okay, and do you have that list? I mean, yes. Okay, good. So again, it's got everything I'm going to say in it. And we're going to talk about the fact in the presentation that you don't try and tell the patient to do 32 different things at once. I don't want you to try and do 32 different things at once. I want you to pick 1 or 2 things, if you're willing, if you think it's relevant, and try and implement them. And then you can always add to that. Okay, introduction. Moving on. So there are many ways to help patients improve adherence, and that any one technique by itself doesn't have much success. The whole idea is that approaching them from many different directions, multifactorial approach is the most effective. So I'm going to go over a lot of different ways that you can help people, and it should be obvious as I teach, as I discuss each one of them. So I'm dividing this into 3 sections. One is practical tips regarding prescribing. Then physician-patient communication, which is, I think, the most important part here, and then system approaches, which we'll discuss when it comes up. Practical tips. I'm just going to throw out a lot of these. A lot of patients, I'm sure in your setting, don't have a lot of money and have mediocre health coverage, so use generics whenever possible. Now, in California, we have access to the Good RX program. Do you have that in Alabama?
Yes.
Yes. Highly recommended. So many of the medications that we should be using for chronic conditions are generic, and with GoodRx, patients can get it for $10 for several months' supply, which really helps with that. And so the corollary is to be aware, in an urgent care setting, you're seeing patients with every different possible permutation of insurances or lack of insurance, to know what kind of insurance they have, because cost can be a major barrier, especially to people who are low on the socioeconomic status scale or poor. And if your patient has not very good drug or no drug coverage, GoodRx, do you have Costco where you are?
Yes.
Yes? No. No, Tanya's saying no. I can't see all your hair. Anyhow, to the extent that you have Costco, non-Costco members can go to Costco, to the pharmacy. You don't have to be a Costco member. Their prices tend to be extremely reasonable. And at least out here, presumably they're GoodRx, which is a national program. You can just print them out a coupon and tell them how to use it. And it gives them the pharmacy, and the prices are really, really excellent for most part. Now, when you get to Victozas, that's another issue. But okay, more practical tips. In every study that I've seen on this, the more often that you want patients to take the medication in the day, the less likely they are to do it. So once daily prescribing is the optimal, and if you have to go to twice a day, though the adherence rates are going to drop off. Encourage the use of pill boxes. I have several medications I take. I'm totally dependent on my pill box. It's Monday. This is Monday. I just pour it into my hand and I set them out once a week. That makes it easier. Suggesting patients take the pills at the same time each day, especially if it's something they're not very used to doing or don't have good habits of, to match it with something else they always do, like when you brush your teeth at night, take your evening pills, etc., etc. And also in terms of convenience, many pharmacies will mail prescriptions. Is that true where you are? Maybe, maybe not. Okay. The extent that the patient doesn't have to spend an hour or two of their time to get the medications, they're more likely to do it. Okay, so those are my practical tips. And a lot of the medications in the algorithms for common disease can be taken once a day, some twice a day. Even metformin, for example, which is often the short-acting, could be twice a day, but there's a long-acting form which is generic, which for many people works better, both because it's easier to remember to take and also because it gives you a more smooth blood level. And some of the metformin side effects we were just discussing a few minutes ago, the first patient that was talked about, are lessened because you don't get the peak and valley of the short-term thing. But that's just another thing. Okay, physician-patient communication. We're going to talk about a number of different ways of doing that. The first is shared decision-making. Okay, well, I've got a case example in here. Mr. E is a 54-year-old white male with a 2-year history of hypertension. He's been prescribed the combination lisinopril hydrochlorothiazide 10, 12.5 milligrams daily for the past year. When he comes in, his BP is 165/98. He says, "Oh, are you taking your medicines?" "Oh, yes, doctor, really, really well." And his last refill of the medicine per the electronic health record was 100 tablets 5 months ago. He denies any symptoms. So he has made 100 tablets last for 150 days. That tends to raise one's suspicion. Now, here is my old way of doing this, of talking to somebody about this. Note, I'm not recommending this, okay? But I'm going to contrast this with the new way we'll talk about. I'm the doc, I'll do both sides. "I see your last refill of your medication was 5 months ago. This means that you're not taking your medicines regularly, as 100 tablets won't last 150 days. Don't you know how dangerous this is?" "I suppose I do miss a dose occasionally, but I must have had extra pills from an earlier prescription." "Your blood pressure is way too high today. This could cause a stroke, heart attack, kidney damage, or worse. You can even die from this." "Is it that bad, doctor?" "Unless you change your ways, these bad things could really happen to you." Okay, I'm exaggerating slightly, but there's truth in that. Where's enter? Okay, so doctor, what can I do? Very simple. You need to take your medications every day at the same time. You also need to exercise more often, reduce salt in your diet, lose 20 pounds, check your home blood pressures daily, reduce your alcohol intake, and keep regular appointments with me. Do you think you can do this? I guess so. Anything wrong with that approach?
Sure, there's something wrong, somebody. Scott is unmuted. Go ahead.
Yeah, it just seems like a lot of pressure on the patient.
I'm sorry, say that again?
It seems like we're putting a lot of pressure on the patient with that approach.
Yes.
And then we also have Christina.
Yeah, it seems like we're asking him to do a lot of things at one time. So.
Absolutely right. Yeah, we're going to talk about that's one of the problems. Both of the problems. Putting pressure on patients backfires. It's bad for the relationship. And also, how well do you respond to pressure? When you talk pressure, another medical term, you can look this up, it's very, very, authoritative, is nagging, okay? Now, have anyone ever nagged you about something that they want you to do to improve your health? Like, "Why don't you exercise more?" Or, "Why are you eating that junk food?" And they say it like that. Do you take that to heart and think this person really has my interest in mind? Or do you go like, "Oh my God, when are they going to stop so I can go and get back to my, bowl of Doritos?" Okay, well, you don't have to answer that, but the answer is pretty obvious. And too much to do, a very bad tone, not trying to understand why Mr. E was not taking his medications regularly and to help him with that. So how do we counter this? Shared decision making. Are they teaching? Is this a concept that you are being taught in your training? Shared decision making. Yes.
I see some yeses. Yep.
I see some yeses. Great. Well, anyhow, you know about that then. So in shared decision making, it means doctor and patient collaborate to develop a treatment plan. It's not as one-sided as the traditional, "You have hypertension, take this." And the first step is a mutual understanding of the nature of the problem. So you will succeed the most if you and the patient become on the same page about why you think with all your years of training and education that they need to be treated for hypertension. And that would include, what is the risk of the condition if it's not treated? And what are the principles of successful treatment? In other words, the more the patient understands of this, the more likely they are to want to take this on, and it becomes their task, not something they're doing because you ask or tell them to do it. And when I've taught this principle before, practitioners say to me, well, that's all well and good, but I've got 15 minutes and the patient has 9 problems, and how on earth can I just have to tell them what to do and hope for the best. Well, a little bit, again, not for urgent care settings so much, but a little bit of investment at the beginning of why this is important will pay off in the end if you're both understanding why this is important. So shared decision making, and to get good shared decision making, you need to be interactive and understand what the patients, how they're understanding the problem, and are you really effectively communicating. So communication tools, I didn't learn the term for this until I started teaching at UCSF. One of the most important is teach back. Are you familiar with that concept? Have you heard that term? Yes, okay. And it doesn't take long, but what I would often say is I know I just said a lot to you about why we need to treat your diabetes, but I'm not sure I'm being clear. How do you understand what I was just saying? I tend to say it that way. You don't want to sound like that you've just finished the presentation and now it's time for the oral quiz and you're being graded. That's not great. But if you put it like, I want to make sure that I have done a good job in communicating to this, and then you can ask more questions like, for example, why do I think it's important to be treated for hypertension? And then the most important communication tool in all of medicine is what we call zipping the mouth. Sit back, listen, give people time. And that really works a good deal of the time. And yes, it's an initial investment of time, but if you do it effectively, you won't have to do it every time you see the patient. The other thing that we ask people to do, though it's less important than the teach back, is anticipate obstacles. Okay, we've come up with a plan that you're going to take this 1 pill a day. You've got the home blood pressure monitor. You're going to start checking your blood pressures and writing them down on a daily basis. Some people find this hard to do. I'm curious, what do you think? Is this a realistic plan for you? Will you be able to do this? And then you want to give patients permission to say the things that they may be embarrassed to say or feel uncomfortable saying, like, I've got the kids in the morning, I'm in a rush, I never get things done, I just can't think of it. You want them to have the space to talk about that so you can problem solve it together. And you want, the term we use, I learned at UCSF also, is to normalize. If you normalize things that patients may be upset about, they're more willing to talk about it. This extends to many different things like, I talk to a lot of my patients about recreational drugs. I'm just curious, do you ever use any recreational drugs? Not relevant to medication non-adherence, but the whole idea is if you normalize it, if you give them permission to be honest with you and don't sound judgmental, you're more likely to get an honest response. So very important communication tools. For particularly diabetes and hypertension, if patients self-monitor, it gives them immediate feedback. I've got hypertension. Someone says, take these pills and you have a 32% less chance of having a stroke in the next 10 years. That's probably true, but it doesn't give you immediate reinforcement. So if they're actually checking their pressure and say, oh my God, I'm taking the pill and my pressures are normal, that's reinforcing. Or now they stick their finger, I'm taking the metformin appropriately and my blood sugars went down from 150 fasting to 98 fasting. That gives them immediate reinforcement in the way that not having a stroke in the next 10 years doesn't quite grab people. So if you could get them to do that, so much the better. I'm going to mention this, but this is a double-edged sword involving family members or friends. This is, this can be tricky because of the confidentiality issues. If a patient brings in a friend, a neighbor, a family member, you want to ask, is it okay if I talk honestly to you in front of this person, et cetera, et cetera. Open that up. And then, and if you think it's going to be constructive, get that other person involved. But again, I mentioned nagging before. With husbands and wives particularly, or partners, nagging can be a common denominator. Like, the doctor said that you should be doing this. Why aren't you doing this? That that doesn't help their relationship and probably doesn't help the behavior we're trying to change. So it's something to be aware of, but use it carefully. Some other communication tools, using I statements. Have you ever heard of using I statements as a communication tool? I'm not seeing anyone nodding their head. With I statements, you say things in a personal manner, like, I'm worried that your blood pressure is staying high, I'm concerned about your factor to health, how this could affect your health. And that sounds a little better for many people than saying, don't you know that if you don't do this, you will ... So something like a human being and not like an authority is always, I believe, often a more effective thing. So I statements, and they can be used in many different contexts. People hear I statements vary. I'm worried. I'm concerned. I'd like you to try. And then to go back to teach back, why do you think I'm concerned about this? And then let them say. And that's a great way to find out, because if the patient doesn't think the problem is important, they're less motivated to deal with it. So if you say, I'm concerned that your blood pressure is too high, why do you think I might be saying that? And you say it nicely and non-judgmentally. And they may likely say, well, I sort of heard that it's good to have a lower blood pressure, but I never really did understand why. So, and then you say, okay, great. And that's a teaching moment for you and the patient, et cetera, et cetera. So I statements, we've already talked about this at the beginning when I said I'm going to give you 20 different tools. Don't try and do them all at once. We medical professionals, doctors, nurse practitioners, physician assistants, we all like to be thorough with our patients. So when someone comes in with a new diagnosis, the temptation is, and something that I've done, for years, is to say, give them the whole wrap all at once. Like, well, in fact, we've identified that you have diabetes. This is actually good news because we can treat it. If we didn't know, I know you're upset about it, but if we didn't treat it, you'd be worse off. So very simply, all you have to do is give up all your favorite foods, start exercising, which you don't like to do, take a sharp thing and stick it into your finger once a day, lose 10 pounds, exercise more, and I've got 3 other medications I want you to take, and I want you to take this class on diabetes, and okay, we're doing a great job. Thoroughness is wonderful, okay? However, what I just described, I did this for years, okay, until I got better at this. Being thorough is overwhelming. And what do people do when they're overwhelmed? They shut down. They go, well, let's see, after I get it, he'll yammer at me for another 10, 15 minutes, then I can go out of here. And I'm a little hungry. I think I've got to go to that Starbucks and get a big latte and maybe a croissant or something like that. That's what's going on in their mind while you're going on about statistics. So you don't want to overwhelm people. And it's okay to just do a few things at once because that improves adherence. So as a first step, why don't we try 1 or 2 things? And there's more you could do for that, but let's work on it 1 step at a time. Now, if someone comes in with a blood pressure of 220 over 130, I withdraw that because then they need more things done. But the great majority of people who are coming with chronic conditions are coming in with milder forms, and there's no rush about that. So if you suspect that the patient is getting overwhelmed, you can even ask them as part of shared decision-making. I'm going to loop back on things to say, there's 3 or 4 things you could do to start off with this, and then we can add things later. Which appeal to you the most? Which would you like to try first? Would you like to try medication? Would you like to try self-monitoring? Would you like to try ... If they make a choice, they're more likely to follow through with that. So, and then they come in on the next visit and the blood pressure has gone from 160 over 92 to 148 over 86. So it's a substantial improvement, but it hasn't met the current sprint guidelines of 130 over 80. Then you can add another element. So incremental approach. And what goes along with incremental approach is the concept of self-efficacy, which is that if you're successful at something, you feel good about yourself and you feel good about the activity. So, and the converse is also true. If you feel like a failure, you're less likely to want to take it on. You're more likely to go into denial about the whole thing and not do it. So the patient who succeeds at one treatment component is more motivated and more willing to take on additional tasks. Rome wasn't built in a day, even though it can make us anxious. Well, I haven't achieved my goal yet after just one visit. One of the wonderful things of primary care as opposed to urgent care is that you get many chances to help patients. And if you develop an effective relationship, and it's not an adversarial and authoritarian patriarchal relationship, but a good effective teamwork relationship, they're more likely to come back to see you. And when patients trust you about one thing and see it work, they're more likely to trust you about another thing. It's all about building relationships, which is, well, that's the key to effectiveness, in my opinion, in primary care. It also makes it a whole lot more fun. You know, I was treating high blood pressure for 38 years, okay, when I was actively present. And there's just the algorithm, you know, start with a diuretic and an ACE inhibitor or an ARB. You know, you can do that, but that's boring. You know, it's good, it's the right thing to do, but it's developing relationships with patients over time and helping them improve their health is what makes it really interesting. So even though some of the stuff I'm saying sounds challenging, it also can be rewarding and even fun, and you get to know patients better. So habit forming. Well, when we think of habit forming, we think of, you know, meth addicts on the street, you know, bad, okay? But there are good habits too. Brushing your teeth, very good habit, helps prevent periodontal disease, gives you better breath, etc. And a lot of patients will brush their teeth. We want habit forming to happen with good things too, because when you form a habit, it becomes less of a decision and more of an automatic behavior. And we want the good things we want people to do to become automatic. So using the toothbrushing as an example, for those of you who do brush your teeth, every night when you're getting ready to go to bed, you think, hey, is this a day that I'm going to brush my teeth? Maybe I should think about it. Well, at least for me, most of the people I've talked about it, it's automatic behavior. I'm, you know, doing whatever I do at nighttime, I take my pills and I brush my teeth. I don't think about it. It's automatic. It's not a choice. And it's become a habit. And habits take away mental processing. It makes things easier to make it a habit. And how do you help people make good habits? Well, you know, repetition is key. If someone, by the way, the science of habits stinks. So a lot of what I'm saying is evidence-based, and I can quote studies on this. Habits are not too well studied, but the literature suggests this, that doing repetition is key. If you do something, some people say, I'm not saying I say this, if you do it every day for 6 weeks, it becomes a habit. I don't know if that's true, but something like that is true. Doing the same thing at the same time each day with the same triggers helps form habits. So you want, if they're brushing their teeth, you want them to say, reach for their pill box and pop the pills at the same time, automatically, not thinking about it. Now, I'm gonna, based upon what I've just said, I'm going to repeat the same case and then ask any one of you on combination, you know, to become, I can be the patient and you can be the doctor and you can address this with me. So it's the same thing as before. Someone think of who wants to be brave here. Okay, the same case. Mr. E, 54-year-old man, hypertension, medication prescribed, his pressure is too high, and he has taken maybe 2/3 of the proper amount of medications in the amount of time since you've seen him. Okay. Oops, I didn't mean to go that forward. Okay, who wants to help me with this?
Feel free to unmute yourselves.
I'm sorry, I didn't, who said that?
No, it was Sharice. I have no answer. I'm waiting. I'm trying to encourage everyone to.
Okay, does anybody want to try? No, you know, this is fun. Role plays. Everybody loves role plays. Not. Anyone willing?
One thing you said about repetition, we can encourage him to take his blood pressure medicine, kind of like you said, after he brushes his teeth or with his morning breakfast.
Yeah. Associating the two makes it automatic, and it can make it automatic. Okay, so I don't have any volunteers. All right, so I'm fine. I'll do both sides. Okay. Now I'll be the doctor. Well, Mr. E, so I see that, you know, from the evidence I have here, like many of my patients, they have trouble taking medications on a regular basis. I'd like to understand this more. You know, first of all, why do you think I'm concerned about that? You know, I've never really been sure, doctor. You know, I know blood pressure is a bad thing.
I think Tanya has a.
Oh, okay, Tanya, are you willing to do it? Go ahead.
I'm faculty at Sanford, but I will be happy. It's hard to be both. So let me try to jump in and play patient for a little bit.
Okay.
Okay. So I pretty much take my medicine every day. Maybe I skip a day or so here or there, but I pretty much take it every day, mostly in the mornings.
Okay. Well, I'm glad to hear that. But I am concerned about the medication use thing here, and I do understand that many patients, it's really, really hard to do in the busy routines, or they don't fully understand. So, Tanya, Ms. Shanahan, Dr. Shanahan,
You can call me Tanya.
okay, Tanya, one of the things I'd like to ask patients is, why am I concerned about this? Why is this an issue? How do you understand that?
So I don't know. I mean, I've been taking this medicine for ever since I got it, and my blood pressure has always been managed, even though sometimes I skip medicine. But it's like if I skip medicine now, it's just not, it just doesn't seem like it's managed as well.
Okay, and have we been clear about what the goal of blood pressure, what blood pressure goals that we're aiming at?
I think I've heard a number before that they would like me to get down to 120 or 130, but I don't know. I just kind of feel bad when it's like that. And so if it starts getting down to like 130, 120s, maybe I do skip a pill so I'll feel better.
Okay, well, I'm really glad that you told me about that, because we always, as doctors, worry that the patients could be having side effects and that maybe we're over-treating you. That 120, 130 systolic number is a goal nationally. However, some patients don't tolerate that. And what happens to you how do you not feel well when your blood pressure is low?
I just feel tired.
Tired. Okay.
Sleepy.
So why don't we aim for a slightly higher blood pressure goal for you, or maybe it's the medication, but this is something we can work on over time. But, you know, and the other thing I want to make sure that we're on the same page about is, what happens if your blood pressures remain too high over time? Do you understand why this is a concern for me and for us in the medical profession?
Well, I know my mom and dad both died of a heart attack early, like in their 50s or 60s. And I guess I don't want to have one. So I probably need to have it a little lower.
Makes total sense. Now, the last thing I'll say, then we'll have to go on, is, do you check your own blood pressure at home?
Sometimes when I go to Walmart, I check it, but there's a pandemic going, so I really don't like to put my arm in that cuff anymore.
Yeah, in the COVID era, I don't even want to go into Walmart anymore. So, you know, for about 30 bucks, you can buy, and Amazon has them, any drugstore has them, blood pressure machines. They've gotten really accurate these days. And if you're able to check your own blood pressure, we'll know if you're getting towards the goal we want. And also, when you're having those symptoms, like I feel tired, etc., you can then check your blood pressure. And if your blood pressure is 110/60, it's too low. We've got a reason. If your blood pressure is 136/84, then that's probably not the reason. It helps us become detectives to understand what's going on. Does that make sense to you?
Yeah, I guess I could get a blood pressure cuff.
Okay.
My daughter has one of those little Amazon accounts.
Yeah.
Stuff just
Perfect.
shows up at the door.
Okay. We'll stop here. We could go on more. But anyhow, the picture is to be interactive, to draw the patient out, and to come up with a plan that's mutually acceptable. So thank you, Tanya, for that. It was much better than my doing both sides of it. I do that, and I tend to exaggerate too. You were more realistic. Anyhow, let's see how we're doing on time. Oh, not much time left. Okay. Team approaches to enhancing adherence. Now, for you who are in urgent care settings and moving around, this is not going to seem as relevant as when you're actually in your final, or not final, in an actual practice. But it takes a village. It's not only on the doctor or NP/PA's responsibility to help people with medication adherence. There are many ways that the team you work with can help. And at Kaiser Permanente, we had a very effective team approach to managing chronic conditions. For example, phase one of using other people, making it a team approach. You don't have to, you want to identify non-adherent patients. One of the things true about non-adherent patients, they often don't show up in your office because they're non-adherent. So if And in fact, if you believe in the best use of time is to get the low-hanging fruit, somebody who has hypertension, hasn't seen you in 2 years, is really someone who needs you more than someone who's coming in, every 3 or 4 months, even if they're not perfectly controlled. So you want to have people who can review the electronic health record and look for diagnosis of hypertension, diabetes, and look for patients who haven't been seen. Now, I know that most EHRs are not optimal for this purpose. They were developed as billing systems, long other topic about the limitations of EHRs, but they can be used for this in many settings to identify either patients who haven't been seen or patients who are not meeting targets. Like at Kaiser, I could get a report of every patient in my practice who is A, on the diabetes registry, and B, has an A1C over 7.5 or over 8 or over 9. If you have limited time, pick the ones who have the worst control, and they're the ones who need the help most, and get them in. Because if you don't see them in the traditional model, out of sight, out of mind. And so we lose a lot of patients who don't come in. So if you can find who they are and get them in, that could be, there are a lot of ways of doing it, looking at medication refill records. Again, this is something that someone other than the practitioner can do. And then there are also people who can counsel patients, like at Kaiser, we have chronic condition programs. People can go to classes. They can have one-to-one meetings with nurse practitioners, particularly if, who specialize, case managers specialize in diabetes. There are a lot of type programs. Now it's more online than in person. It used to be in person. It will be in person again. Other people can work with you and to help reinforce that message. So the handout that I've got is I would appreciate, your patients would appreciate when we finish this, if you don't have to immediately go on to something, look at it. It has everything that I've talked about here in it, and make a little check mark. I want to try 1 and 3 or 2 and 10 or whatever, et cetera, et cetera. Pick 1 or 2 things that appeal to you that you think you could try. And again, in terms of what we talked about before, incremental change, self-efficacy, for you as the practitioner, try 1 or 2 things and see if how you feel doing it, how the patients regard it. That it's true for both you and for the patient that change, very difficult to do. It requires motivation, commitment, a specific plan, and then I didn't put it here, monitoring. So this is something I would appreciate you're doing. I think you would appreciate it. So let me just, does anyone here have a volunteer, something that they're gonna write on their checklist and like to try?
I plan on using the I format in the future, just telling the patient I feel or I believe. I think it shows that I'm caring more than just telling them what I believe is the best for them.
Great. I think that's an excellent one. By the way, a little added bonus to that is that this works in your private life too, okay? So next time you and your best friend or your partner or your child or who's has something going on that you're concerned about, using I statements is a more effective way, but we're not talking about your home personal life. I'm just saying that is something, it's a great communication tool. I got good at this to the extent that I am good at it, partially because my wife is a psychotherapist. And after a while, she would say, I don't like the way we're arguing, Fred. I want you to try this way. So I learned to adopt those tools. Now, not all of us have that benefit, but we can still do it. So does anybody else have something that they would like to share that they would like to try?
I plan to use the I statements, the teach back, as well as shared decision making. I think shared decision making is one that will be like the most effective, because a lot of times patients come in and they already have something in mind they want or they expect from us as providers.
Absolutely, that's very, those are really important tools, and you're right. We didn't have a chance to talk about that. For any medical visit, the patient has their agenda and you have your agenda. Sometimes they are totally united, and sometimes it's like this, they're barely touching. And so shared decision making is a way of getting out the topics that are important to the patient, because if the patient comes in with a bad rash on their hand that really bothers them and you want to talk about their hypertension, and they're not going to think you're a good doctor or they're a good nurse practitioner. So if you can address the rash, you've got a little eczema there, I'm going to prescribe you a cream that's really going to help that. Now, I would also like to talk about your blood pressure, if that's okay. That really, really effective. So Now, a couple of questions for you. I developed this presentation primarily for physicians. I have worked with nurse practitioners and taught nurse practitioners over the years, but for your current experience, was there anything about this presentation that I should have tailored to make it better to your reality, either your current reality or your predicted reality when you finish training?
I believe it was right on target for our area and the role of the nurse practitioner in our area.
Okay, good. I don't have to make changes. Then also, I have never been to Alabama. I have to confess that I don't know much about the communities you're practicing in. I always have to at least bring up cultural issues. Are there any cultural issues? Are there any predominant cultural issues that would affect relations between doctor or nurse practitioner and patient, or affect how people understand medication? Is there anything that would, the part of the country you're in, or the socioeconomic, the ethnic group that you work with, that would have a specific impact on how this would work?
The diet and lifestyle in the South, we typically eat a lot of fried foods, just not healthy foods, and then sometimes the literacy levels of the patient.
Okay, so nutrition, particular nutritional issues, the regional and cultural, and health literacy, which we haven't talked about, but only so much I got put into a presentation. But it's really great that you bring up the topic of health literacy, because we have to adjust how we talk to people based upon our assumption of their health literacy. And by the way, when you do the teach back, you get it's a good, if you do it nicely, non-judgmentally, it's a good way of understanding someone's health literacy. And that's a very important concept. At Kaiser Oakland, my patient at 9:15 could be an AC Transit bus driver who dropped out of high school at the 9th grade. My next patient is a professor at UC Berkeley, and I don't talk to them the same. I try and be equally respectful and use the same techniques, but obviously it'd be very different. So, and this is something that's good to be aware of too. So anyhow,
Dr. Kleinsinger, yes. I just wanted to interject. I will be leaving this session right now, but my colleague Jill Einstein will be staying on with you guys to wrap things up and to kind of facilitate the Q&A. So I know we started a little late, so please feel free to continue, and Jill will be hosting this call. Thank you, everyone from Stanford, and I hope to see you next month.
Thank you.
Thank you, Charisse. So anyhow, the goals, overview of techniques, and to facilitate development of a specific adherence improvement plan. That's what I wanted out of this.